Afternoon, everyone. Thank you so much for joining us for our lunchtime conversations during our Aging at Altitude series. My name is Lindsay Haynes. I am the event manager with Prairie Mountain Media, and I will be moderating today's session. So our Zoom webinar format gives you the opportunity to submit questions for our speaker at any point in time during today's presentation. So whether you're on a computer, a phone, or a tablet, you just click on the question and answer button that's on the bottom of your Zoom screen. You can insert your question there, or you can submit us a chat. So today we cover the topic of brain health, depression, dementia, and delirium, those 3 Ds, the difference of each, and then how to treat. Our presenter today is Dr. Haleh Nekoorad-Long. She is a board-certified geriatric psychiatrist with AltaVita Senior Residences. So with that being said, I will go ahead and transfer over to you, Haleh, and we'll let you get started.
Thank you. So hello, let me start the video. So hi everybody, thanks for taking your lunch time to spend it with us. And as Lindsay said, I'm a psychiatrist, an adult and geriatric psychiatrist. So basically, my main focus is on older adults. And in this topic, we're trying to kind of, and it's a huge topic because it is very important to kind of decipher between dementia, delirium, depression. But I'm going to try to do it in 45 minutes because I know that's how much we have, but also I would like to answer any questions. So if there's anything that pops out, please, like Lindsay said, write it in and I'll try to get to it. And if we don't have time, I'm always glad to email back answers if there's any need to do that. So basically, when we are talking about the 3 Ds, for me, it's understanding the differences of trying to decipher what's dementia, what's depression, and what's delirium. The meaning of dementia, this is one of the important things, if you get anything out of this talk, is that dementia is the same for everyone, but then there are different causes. So to me, it would be like if you say I have cancer, but then what type of cancer you have. So the meaning of dementia is impairment in short-term, long-term memory, impairment in abstract reasoning, or judgment, impairment in judgment, personality changes. So some people are like really, they get really depressed or they get really agitated or they become very isolative. So there's a personality change from their baseline. Then there is apraxia at the end of your dementia, which is forgetting how to do things. And this can start with something simple like using the remote for the TV or using the phone. And then it gets into, as your dementia progresses, it becomes more of like something simple like brushing your hair, brushing your teeth, changing your underwear, using the microwave. So it's forgetting how to do things. And then aphasia, which is difficulty with speech. This can be 2 different ways. One is what we call expressive aphasia, which is difficulty expressing yourself. And the other one is comprehensive aphasia, which is difficulty understanding what you're being told, which can be a part of agitated behaviors, because if you don't know what this other person is trying to tell you or ask you, it can cause agitation because you don't know what's expected out of you. So this is meaning of dementia. So everybody who has dementia should meet these criteria. But then there's different types of dementias, which is the reason that everybody thinks of Alzheimer's dementia you know, I've been asked this so many times, is that so my loved one has dementia, not Alzheimer's, or they have Alzheimer's but not dementia. So this is what I was telling you about when you talk about causes of dementia or types of cancer. So if you say, I have cancer, then people are like, well, what type of cancer do you have? So to me, it's in the same category. So you say, I have dementia, and then what type of dementia? Number one cause of dementia is Alzheimer's dementia, and that's why everybody, that's the first thing they think about is Alzheimer's. So 50 to 65% of patients. Second type is vascular type. So if you've had any type of stroke or mini strokes or TIAs, you're at high risk, or hypertension, you're at high risk of vascular type dementia. And there's one that's Lewy body dementia. This one gets really confused with Parkinson's dementia. But Lewy body dementia is 10 to 15%, and then frontotemporal lobe dementia, which is 5 to 8%. And in Parkinson's patients, if they live long enough with Parkinson's, 40% of them will develop dementia. And this can be a whole topic of its own with different types of dementias, but for today, I'm just going to focus on what it means to kind of have dementia and why you have different types. And this one is a really nice visual because, you know, when people talk about dementia types, we always think of Alzheimer's because it is number one cause of dementia. But the nice part about this visual is that as you age with dementia and your dementia worsens, as you can see, your brain is shrinking. So I always, you know, our brain is a protein. So if, you know, that commercial of this is your brain on drugs. So if you have, hopefully most of us have this normal plump type of brain, but as you progress with the dementia, you can have these tangles and plaques. So basically, your brain starts to kind of look like a Swiss cheese a little because it gets these holes in the brain. And as that happens, the brain kind of shrinks. As you can see, your frontal lobes shrink a lot more. Your back of the lobe, the temporal lobes shrink a lot more. And as the brain shrinks, of course, this will have effect on your body. So when this part of the brain starts shrinking at the end of the dementia, this is when you start having difficulty with your gait, difficulty with agitation. Frontal lobes have to do with speech, you know, what I was talking about, aphasia, apraxia. This is the frontal lobe function. So again, this is a nice visual because as you can see, unfortunately, as your brain shrinks, you have more difficulty doing the functions that you used to do. And this one also a really nice visual. It's a PET scan. And this first series is a normal brain again. So hopefully most of us have this type of, and you want a lot of red, which red means you have nice metabolic system, nice blood flow. And this one is what we call myocognitive impairment. So it's at the beginning of stages of dementia when you're starting to see a little more problems with memory, a little more problems with decision making. And this is the front of the brain. So as you can see, the front still works a little, but the temporal lobes are a little more affected. This is severe dementia. So frontal lobes are affected, temporal lobes are affected. And this is a 5-year-old brain. And the reason I show this is really nice visual for caregivers, be it at memory care or if you're a caregiver at home. And I'm not saying you become a child, but your brain starts to look like a child. So therefore, people start having problems with tantrums, problems with understanding what the rules are, not wanting to eat, not wanting to take showers. So if you remember that this person is not doing it on purpose, it's just their brain is not functioning anymore, it makes it a little easier to understand or deal with it. So again, this is a normal brain. This is mild cognitive impairment at the beginning stages of the dementia, severe dementia, 5-year-old brain. And this one is also another visual which kind of makes a little more sense to understand that, I've talked to people that do primary care clinics, and sometimes they say, oh, we don't have a lot of dementia patients in our clinic, but that can't be true because after age 65, 11% of patients have dementia. And 1 out of 9 older adults after age 65 meet the diagnosis of dementia. And after age 85, it's 32 to 40% rate of dementia. So that tells you that in memory care or even in regular assisted living, independent living, that we're going to see more and more people with dementia diagnosis. And 68% are women, and this has to do, we think, with a couple of things. One is that women live longer, so that may have something to do with it. And today we're at 6.2 million Americans that have dementia, and by year 2050, we think it's going to be 14 million. So this is going to be more and more, and again, it's because we're living longer, and number one risk of Alzheimer's is age. So this is just some facts and figures that I picked up from alz.org. If you haven't been on that website, this is an awesome website for information, for stuff that's available in your area. Alzheimer's Association Walk, meeting groups for families, for patients. So it's really nice if you haven't visited it. But this also says, 1 in 9 older Americans after age 65 have, suffer from dementia or Alzheimer's type, and then Alzheimer's is 6th leading cause of death in the US. Over 16 million Americans provide unpaid care for someone with Alzheimer's, which that includes, the spouses, children's, nieces, nephews. Those are the unpaid caregivers. Direct cost is 305 billion, and there's 244 billion unpaid care. So that's for, when you take time off to take care of your loved one, or you quit your job to take care of your loved one. So it's a huge cost for everybody. So one of the things we're going to talk about quickly is there are, as the topic said, there's some things that look like dementia, but can be treated and can reverse the dementia. So some of them are B12 folic acid deficiency. So usually you see this in people that have had heavy use of alcohol, or malnutrition because they live by themselves, they're not eating well. Thyroid disease could look like a little like dementia. Any type of brain infection, syphilis, HIV. And then there is a condition called normal pressure hydrocephalus. This is when your brain is not emptying CSF fluid, so you have fluid buildup in the brain. This can be very reversible if it's caught early. Brain tumors, subdural hematoma, which is if you fall and hit your head, or you're in a car accident and you have a whiplash, it could cause a hematoma. So this also can be reversible if caught early. They can evacuate the blood, and people usually improve or recover. Strokes, sometimes there's not much you can do to reverse the stroke, but at least you know that this is not Alzheimer's, it's vascular type. And if you have Parkinson's or Huntington disease, which is brain diseases, substance induced. So this is also a huge one, because I think in elderly and also over the last year with pandemic, there's been a huge increase of alcohol use. And sometimes it looks like, you know, people that are alcoholic or they continue to use, they can look like they have memory problems and dementia illnesses. But sometimes it's reversible if you stop. But if you have drank for years and years, that cannot be reversed, basically. Depression. So this is a term that we call pseudo dementia. And again, just like the name as pseudo, which means false dementia. So sometimes, and that's why I put it in here, because sometimes depression, when it goes untreated, it can mimic dementia. So it looks like you're having difficulty concentrating, not doing the things you used to do, not getting out of the house, not eating, not sleeping. And it looks like that, what we call pseudo dementia. So the nice thing about this one is that when you treat the depression, a lot of times the cognitive stuff reverses. Dementia Workup, we have, you know, you can start with your primary care physician and tell them that you're worried about your memory or your difficulty making decisions, or if you're worried about a loved one, start with the PCP, because there's some things that they can do, because we just don't have enough neurologists or geriatric psychiatrists that can look into it. But you can start with the you know, physical and neurological exam, the labs, which include, like I said, you know, B12, folic acid can be reversible, thyroid disease, a urine analysis to make sure you don't have a urine infection, HIV if it's indicated, syphilis, CBC, or sometimes you can have like low sodium that can make it look like you're very confused and disoriented, and it can be something very simple to fix. And then you want some brain imaging. A lot of times PET scans aren't covered with Medicare, so you can start with just something simple like a CT scan, sorry, just like a CT scan that shows any red herring, and then if it's abnormal and they want to do an MRI, you can do that, but it can be something as simple as CT, 20 minutes, and you're done. Neurosight testing is for people that you're having a hard time decipher if this person has true dementia or if it's something else, if it's pseudo dementia, or if they have been alcoholic, or if they have Parkinson's. The nice thing about neurosight testing is that Medicare covers it. It is a long test. It's about 3 to 4 hours. But again, Medicare covers it. So it's nice to have it done if there's any question of, is this dementia or is this something else we're dealing with? And then always question alcohol or pain med use, because sometimes people think, you know, that I've asked before when people say that, yeah, I don't drink, but they don't consider beer as drinking. They always think like they don't drink liquor, so therefore they don't report it. Um, so that's really important. Pain use medication, and we're getting a lot better with the pain medication use because there's an initiative in Colorado, and I think actually it's going to be in the U.S. that we're trying to prevent opioid dependence. So we're getting better, and there are ways that physicians can check and see if this person is on long-term use of opioids or not. But that's really important to make sure that those are checked. And then, like I said, depression and anxiety screen is really important. Insomnia, if the person has really severe apnea and they're losing oxygen during the night, that can affect their brain function the next day. It can look like you have dementia. If you use CPAP, a lot of times people's memory improves the next day. And the main one is ruling out delirium, which we'll talk about in a minute. But so first you want to do the dementia workup, but we don't have a lot of treatments. And the reason I remember this is because when my daughter was born 22 years ago is when Namenda came out. So we haven't had anything new for 22 years, which is a shame, but it's the facts. And these are not great medications, great treatments, but this is all we have. But the important thing is that early diagnosis is crucial because a lot of these medications are more effective if you start early in your disease rather than waiting until it's too late to use. So early diagnosis is crucial. Treating the medical problems is crucial. And like I said, there's no really good treatments, but if you start sooner than later, it's better. And then we're going to talk about delirium because, like I said, that can look like that you have dementia, but you can't really make a diagnosis of dementia when you are delirious. And definition of delirium is, 30 to 50% of ill geriatric patients become delirious at some point during their life or during their hospital stay. And I can assure you, all of us have been delirious at one point. If you had any sort of surgery, anesthesia, you are delirious the next day. If you had really high fever, you've been delirious. So one key point about this is it's a very rapid onset, so it's hours to days. And one saving grace is that it's a brief duration, so it can be from days to weeks. So it's transient. So hopefully you go away. That's why you don't diagnose dementia when you're in the midst of a delirium picture. And one way of telling it is that it really happened fast. So like when they call me and they say, Mr. Smith is all of a sudden agitated, they're throwing things, and they weren't doing this the day before, 2 days ago, and it has happened quickly. They're more confused, they're very irritable, they're psychotic. The first thing to rule out is a delirium picture. And they sundown really bad, which is they're okay during the day, but by the time it's in the evening, they become very confused, very agitated, psychotic. They're disoriented. They're not the same. And again, one key is it's a rapid onset and they have something medical going on. Number one, and then they're disrupted of sleep-wake. So they're up at night, sleeping during the day. Number one cause of delirium in patients with older patients is urinary tract infection. And it's very easy to fix, but sometimes you can treat the infection, but they may still be delirious for a couple of weeks or 3 to 4 weeks, even after you've treated the infection. Many other medical problems cause it, but number one is urinary tract infection, which is nice because it's easy to fix. But dehydration can do it, pneumonia can do it, flu can do it, COVID can do it, constipation, infections after stroke, if you have low sugar, high sugar, thyroid disease, or low oxygen. And some of the drugs are horrendous for this. Benadryl is number one, which Benadryl is in Tylenol PM and Advil PM. And those are the ones that older people usually love to take because if they can't sleep, they're like, well, it says Advil PM. Oh, I have pain. Might as well kill two birds with one stone, but it can make you really confused, Benadryl can. So try to stay away from that. Pain medications, which is opioids, lithium, Sinemet, which is carbidopa, levodopa for Parkinson's. Then I talked about anesthesia. If any of us have had anesthesia post-surgery, you get pretty delirious. And then alcohol and benzos. Benzos are like things like Ativan, Valium, Xanax. And then drug withdrawal, alcohol, benzos, opioids. Again, sometimes people are embarrassed of talking about their alcohol use and they come and have like a simple surgery, but they don't share that they were drinking 2 or 3 beers a night or 2 or 3 vodkas at night. So when they have the surgery and the anesthesiologist doesn't know, they can go through a pretty bad withdrawal, which looks like delirium. And delirium treatment is, identifying the medical problem and treating it. So like I said, if there's a UTI, treat the UTI. If it's a withdrawal, you treat the withdrawal. And another thing is if they're in ICU, keeping the environment quiet. But how do you keep the environment quiet in ICU? Because the lights are on and off. There's always alarms in their room or neighbor's room. So really the best thing for them is to actually get them out of the hospital back into their familiar environment. So you would want to treat it, obviously, but you also want to get them out of the hospital as soon as you can. And then, of course, hydrating and monitoring their food intake, and then if they're irritable or psychotic, using antipsychotic medications. Depression in older adults sometimes can be tricky to diagnose because a lot of older adults, they don't like to admit that they're depressed because, back in your time, that, it was kind of like pull yourself up and don't complain. My generation is very good at complaining. We talk about our feelings all the time, but the older generations, 70s and 80s, they don't complain about being depressed. And a lot of times they can have somatic or physical problems, which can go hand in hand with depression, but it gets missed because you think probably something medical is going on rather than just depression. And like I said, less often they report depression or guilt. And a lot of times, like especially in men, I would say that depression presents itself with an agitated, irritable mood, rather than being tearful or sad or wanting to die. So a lot of older men with depression end up being agitated and irritable rather than tearful and sad in women. Again, challenges are because a lot of times they overlap with sleep disorder, with fatigue, decreasing appetite, and then seriously ill patients may focus on death and dying, not per se suicide. I've had this so many times that, people are like, no, I mean, I don't want to like kill myself, but I really would like to be dead and don't wake up the next day. So again, that kind of gets in that gray area of, are they depressed? Is it because they're medically ill? Is it because they're on hospice and they want to die? So it all kind of gets a little difficult to diagnose. Pseudo dementia, like I said, depression can mimic dementia. So you really, really want to make sure that if you're dealing with depression, you want to treat the depression before you diagnose someone with dementia, because it may not be a true dementia, it may be pseudo dementia. And I know this is a little busy, but look at how dementia, depression, and anxiety, they all overlap together. And that's why you have to make sure that you're not missing, one of them, because it can be like with dementia, they can have depressive symptoms. With depression, obviously they have depressive symptoms. With anxiety, they also have symptoms of dementia. So it's very important to kind of decipher what's what. And sometimes reasons for delayed diagnosis of dementia can be that we make excuses, like it could be normal aging, and it can be so insidious that it gets missed, because you see them every day and you kind of feel like, they're in their 70s or early 80s. I mean, don't you have memory problems? And the only thing normal about aging is that your processing time changes, it gets longer. So if it took you like 20 minutes to do your checkbook, it would take you 40 minutes to do your checkbook, but you still can do your checkbook. So that's the only normal thing about aging. So just because you're aging doesn't mean that you are going to have memory problems or depression. So that's not normal. So get help. And the best one, this is why I do what I do, is denial. How many times, have you seen your loved ones? I mean, this was definitely, I know it's a lady's picture, but this was definitely my dad. My dad has dementia, that he was very defensive. He didn't want to quit driving. He actually crashed a car because he didn't listen to not driving. So a lot of times denial is a huge one for delayed diagnosis, but not only on patients' parts. Sometimes the doctors who've had a good relationship with this patient, they've known him for 20, 25 years, they don't want to diagnose them. Sometimes the family doesn't want to know, because then they're like, oh, I have to deal with what's next. So a lot of times denial is a huge, huge part. Treatment with medications, again, we don't have really good treatments for dementia. However, the ones that we do, if you start early, the sooner you start, the better, because it slows the deterioration. So if you can slow down the deterioration, and because we know nothing, we don't have anything that reverses it, you can slow down, you can delay nursing home placement by almost 2 years, which is huge. And then some of the non-pharmacological management, I'm going to run through this a little quicker because I know I'm running out of time. Safety is number one, obviously, because especially if they're still living at home by themselves or with a spouse or a caregiver. So I call it child-proofing the house, but it's dementia-proofing the house, like making sure that they can't get out of the house and get lost, or that they can't use the oven. Sometimes you can unplug the oven if it's electrical. If it's gas, you can pull the knobs off so they can't turn on the gas. Hiding their keys or disabling their car. so they can't drive if they're, unsafe to drive. Um, and, when they're really putting up a fight, you can do a driving test. The problem is insurance doesn't pay for this service, the driving test service, and it is like $340 out of pocket. But if they're, you know, really gung-ho that they want to drive and they don't believe the doctors, you can always get them tested. And then, of course, another safety is limiting financial responsibilities or decision making, because it's huge, huge, huge that people can be taken advantage of financially. And maintaining a calm and peaceful atmosphere at night is very important. Dim lighting, peaceful music, and routine. They thrive with routine. So keeping things similar, keeping things familiar, having like their own little chair or bed, blanket. And then, of course, sanity of the caregivers. Unfortunately, right now, daycare centers are closed because of COVID. Hopefully, in the close future, that can be restarted, because that was so huge. Like for my mom, because my dad went to daycare, that was really huge for her to have that 6 hours to herself. And then respite care. So the way this works is like a week, 2 weeks at a memory care center where the family can leave them and take a vacation, or sometimes, unfortunately, a lot of times what happens is they have to have surgery. Caregiver has to have surgery. So they put the person in a memory care unit so they can take care of their own needs. And this is huge, the sign of stress in caregivers. And like I said at the beginning, $244 billion unpaid caregiving dollars, but it also has a toll on emotionally, not just financially, but emotionally. And if you look at these signs of stress, anger, anxiety, denial, depression, exhaustion, health problem, irritability, lack of concentration, sleeplessness, social withdrawal, you think you're looking at the patient, not the caregiver, but they suffer. And, they said 50% of the caregivers actually meet the criteria for depression. Let's think of the isolation. Like for my own mother, she stopped going out because she was embarrassed of my dad's behaviors. It was really hard to take him out. And he had to go to the bathroom all the time. So she got very, very isolated. Her world got really small. And so it's really important to take care of yourself as much as you're taking care of the other person. I like this one because it says, what you need is a bit of human caring, a gentle, reassuring touch, warm smile that shows concern, all of which I'm afraid were not part of my medical training. But what I'm saying is a lot of times the doctors don't have a lot of time, because, they not only have to deal with the dementia, they have 4 or 5 other medical problems, hypertension, diabetes, all these other things before you go, oh my God, but I'm like so tired of taking care of this person. They're not sleeping, they're not eating, so in that case, AAGP, which is American Association of Geriatric Psychiatry, has a lot of good resources. But my favorite is Alzheimer's Association, which is alz.org. They have a contact center. They're actually paid people that answer the phone, so they know what they're talking about. They know how to walk you through what you're going through. It's a 24-hour number. And if you're having trouble in the middle of the night trying to figure out how to deal with this person that has dementia, and it doesn't have to be just Alzheimer's, it can be any type of dementia, vascular, Parkinson's, any type of dementia, you can reach these people and they're very good. And safety, number one. So up to 26% of skilled nursing facility patients wonder, but this number is huge because up to 60% of patients who reside in a community wonder. And this is talking about community being their own home, or like an unlocked community, like assisted living or independent living situation, or a nursing home situation that's not locked. So 60% of patients with dementia end up wonder. If they're not located within 24 hours, 46% of them will die of either hypothermia or dehydration. And the problem is no one can ever predict when the wandering will occur. Like, again, I use my dad's example because not only I have to deal with other patients, but I have to deal with my own dad. And at the beginning, he would go on walks, but poor guy couldn't remember how to get back. So me and my kids would get on bikes and go look for my dad behind the house and walking trails. And it was quite an ordeal, but we found them. This happened 3 times. And then we finally convinced my mom that he should not go on a walk on his own and that we should put a double lock behind the door. But it can happen to anyone. It can happen at any time. This is, like I said, the ALZ.org. If you go on their website, they have what they call a safe return bracelet, which you sign up for through the Alzheimer's Association. The really nice thing about this is it is the bracelet that you get, but you can't undo it on your own. You have to use 2 fingernails to undo it. So the patient themselves can't get it off, so it's there to stay. Another nice part is that it just has their first name and then an ID number. And you call the 800 number on the back of the bracelet with the ID number, and then they alert the loved ones. But also, it is 24-hour, but if somehow you come home and your loved one is not there and you're like, oh my gosh, what happened? You call the 800 number yourself, and what they do, they send fax alert notification to all the police departments in the area, and they start looking for the person quickly. So that is, look at that, I'm on time. So that is my last slide as far as the lecture goes, but I'm just going to put in a plug for AltaVita. We are actually a senior continuum care community. So there's independent living, assisted living, and memory care. But the memory care is what I'm going to focus on today, since this is a dementia talk. It is a neighborhood concept. We do have a respite program. We hopefully start, I think we've already started tours again, but we can ask Adam in a minute. But the nice thing about our company is that we are family owned, Longmont owned family. And we have set it up like a home situation. So, and there are 4 different neighborhoods. So everybody, you know, yes, there is like 50 something residents. However, you only live with like 12 to 14 residents together. So they have their own dining rooms. They each have their own private bedrooms. And last thing is, if you want to get on our mailing list for future updates, we I do these educational series, and we have other people too that do different educational training, and you can get on a mailing or email list, and we'd be glad to send them to you. But with that, that is my last slide. So if you have any, let me see what the questions are.
Yeah, so I'll go ahead. There were some Dr. Long that came in during your presentation, so I'll start with a couple of those. So the first one that we had was this person's wondering if you could comment or provide any information relating to using antipsychotic drugs with dementia patients or with people with behavioral problems.
Yes, great question. So I know it's scary because when you look it up online, it's going to say it has a black box warning for antipsychotic use in dementia patients with psychosis. But the problem is, what am I going to do? I don't have a magic wand. I don't have a magic pill. And this person is suffering, and not only they're suffering, other people around them are suffering. Um, so the history is that about 10 years ago, there was a study with Risperdal, which was which had shown that there was an increased risk of death with patients that had dementia with behavioral problems. But the problem was that they didn't look at that these people had multiple medical problems. They already had strokes. They already were falling. So they were at the end of their disease stage. And then when you added the Risperdal, yes, it increased risk of death, but it was already, these people were kind of compromised with their medical problems. And the risk of death is actually like less than 1%. So it's not a huge number, but I know it's still scary. But again, you have to kind of weigh the risk versus benefit. So if somebody is psychotic, thinking that the Nazis are going to come after them, they're not eating because they're hiding under at the table. I mean, this is a true story that I'm using. There was a woman who unfortunately had lived through that as a child. And then she was reliving those moments. She was hiding under the desk. She wouldn't eat because she thought the Nazis were coming. And then when there were snacks, she would hide them in her pocket. She still wouldn't eat them because she was going to keep them for later. And then when I talked to the family regarding the risk, they were like, oh my gosh, give it to her. I mean, this is horrible for her to live like this. And guess what? She got better. She wasn't thinking that anymore. She was eating with everybody else. She was sleeping through the night. So we were able to give her quality of life for however many years she had left. And another thing I always present too is quality versus quantity. So if you're worried about this person dying, I don't know, 6 months sooner, but they're going to be suffering for this 6 months, you have to look in your heart to be like, okay, if this was me, would I want to live this way? I mean, if it was me, I wouldn't. So,
Right.
but yes, so I know it's really scary when you look it up online, but you have to take it with grain and salt and also risk versus benefit. And we do have some medications that are safer than others, like Seroquel is safer for dementia patients. There's a medicine called Haleh. It's an old medicine. That one has a lot of side effects. I usually try not to use older antipsychotics, use newer ones.
Great. So our next question that came up, so for brain health overall, what about like gym exercises, games, puzzles? Do those have any preventative value for brain health?
So the best thing, so they've done studies with, and there was like 7 different things that we're looking at. One was exercise, one was puzzles, one was omega-3, one was hormone replacement, CoQ10, cholesterol medication. I don't remember the 7th one, but there was like 7 things that they looked at. The best thing was exercise, and it wasn't like you have to work out every day for an hour. It was actually only 20 minutes 20 to 25-minute aerobic exercise. So to the point that you're not able to talk, 20 to 25 minutes, 3 to 4 times a week. So it's not like you have to be a gym rat to save your brain, but also whatever is good for your heart is good for your brain. So Mediterranean diet, you make sure you keep your cholesterol low, you make sure you keep your blood sugar under control, and all those things that I said, thyroid, B12, folic acid. But from everything that they have tried, and they're saying, don't stop doing puzzles because that's probably good for something, but the best one is exercise.
Great. So, what kind of memory issues should be of the most concern to consider when you're going in for a screening? So, this person said, for example, like if you start forgetting people's names or you repeat yourself, is that normal or is it more on the concern level?
So, again, the only normal thing about aging is processing time. So, you may, like, I may not remember Lindsay's name at the moment, or like next time I see her, I'm like, oh my God, I know that girl. But,
Right.
it comes to me 20 minutes later and I'll be like, okay, I'm safe. If it comes to you later, again, it's a processing time issue. But if you totally, it's out of your brain, out of your mind, and you totally don't remember, and I don't consider names like being very concerning because especially if it's someone you don't always run into. But if you start forgetting like your sister's name or your children's name, then that should be very alarming. Forgetting conversations, that can be the start of something, because if you have no recollection of having this conversation with someone, and then you tell them that, yes, we did, and they start getting agitated, and that's usually not their personality. So you're seeing a little bit of a personality change too. I would say that's concerning. But if you're able to do things like it just takes you longer, that's normal. And if you're able to remember Lindsay's name right after I leave this room and I go upstairs, I'm like, oh, yeah, it was Lindsay.
Yeah.
So that's normal.
Good.
But if you have, so I give you one example. I have a lady, unfortunately, she passed, but I mean, this was 15 years ago. She came to me, her only concern was that she had been a cashier at Macy's for 23 years, and she had stopped remembering how to do cash change when they would give her cash. That was her only concern. But her other concern was I had my mom and my aunt that I took care of who had dementia. And I'm terrified that that's what's going to happen to me. So I sent her, actually, I believed her because I was like, yes, I agree. If you've done this for 23 years and now you can't do cash change. So I send her for Neurosight Testing because that's the best way to tell if at the beginning part, like at MCI level. And she did qualify for MCI, so mild cognitive impairment. And I knew her for like 13 years, so we grow old together. But at the end, after 7-8 years, she started to develop dementia. But the nice part with that one was because we figured it out, and having family history, I started on all sorts of medications that we had. And I still believe that the reason she had 12 good years was because we picked it up normal at an early stage and had her on medications. But she was able to be independent, living on her own for like 7-8 years, moved into assisted living and then the memory care. So I think she had like, extra years of good life because of being picked up early.
Right. Good. Okay, so for somebody that's in your family or a loved one or even a spouse, I know you touched on some of the safety features that you can do around the house, but For someone who is experiencing a family member who's showing those first signs, I mean, what is your recommendation to them? Because they're going through it as well, right? And I know you kind of started to talk about it, but I just wanted to give you the opportunity to
So
kind
you're worried about the family or yourself?
like the family member or a loved one when they're
Okay,
starting to show signs, like what's some, advice that you could give to
right. So first of all, you need to talk to them and see if they're reasonable enough to agree with you. Because sometimes they're putting up that wall because they know what's coming next, which is, oh, I know what you're going to do. Next, you're going to tell me I can't drive. Then you're going to tell me I can't take my own medications. Then you're going to tell me I have to move to a facility,
them.
or, I have to give up my money or whatever. So, first thing first is to talk to the person directly and see where they're at with their acceptance. Because maybe they're afraid too, that, oh my gosh, yes, I am forgetting conversations or I'm forgetting names, but I don't want to bring it up to anyone because maybe they haven't noticed, so we're cool. So have a conversation with them first, and maybe you can do it like with somebody else. So there's three of you rather than just two people. So you have a backup plan too, and then just see how they approach it or how they see it. Like I give you my own example was my dad, and he never accepted it. And even my mom never accepted it, especially at the beginning. And she would still let him drive, even though everybody had told him not to drive. And the reason he stopped driving was because he totaled their car
Mhm.
at an intersection. And they both could have died and killed someone else because it was a really bad accident on Ken Pratt and Hover. So they both could have died, but it took that much of a huge impact for them to stop driving. So have a conversation with the person first, see what their acceptance level is. If they're not accepting it and you're still worried, get a backup of who else is available, whatever support system. Talk to their primary care physician. If they're refusing to go in with you with the primary care physician, you can always just fax a note or leave a message, because sometimes if they don't have release of information, they're unable to talk to you about that person. But being a physician, I know that I always welcome more information because all I see is that 20-minute interaction with the patient.
Mhm.
It's nice for me to see what they're doing at home. So if you're worried this person is like, oh my gosh, they left their spoon in a microwave, which is true story. They've done that. I've heard that story before too. So you can either fax or leave a message for the primary care physician and kind of go there. And then if it comes worse to worse and you're really worried and they're not willing to stop and you're worried about their safety, Adult Protective Services is the last resort.
Mhm.
Because you're worried about them, but you also worry about people around them. Like this person who had left the spoon in the microwave. I mean, she lived in an independent living place. She could have put the whole place on fire.
Right.
Um, so you're not just worried about them, you're worried about other people around them. Another example, I said, don't leave this person alone. They should not cook or bake. And this lady just loved cooking and baking. And this is also a horrible story, but I always tell the horrible stories because I want people to know that it can happen to anyone.
Right.
But so the husband had left her alone for 35 minutes to go to grocery store and come back. When he came back, the woman had caught herself on fire trying to make coffee on the percolator, those old percolators that you use, and they had gas oven.
Mm.
She had reached out and she was wearing, one of those muumuus, the big sleeve.
Yeah.
She had caught on fire. Like he had to put her out fire. He put blanket on her and then call 911. So And again, the only reason I tell all these horrible stories to, yes, to scare people that it can happen.
Mm-hmm.
So.
Well, great. Well, thank you so much, Dr. Long. We are already up at 1 o'clock, so I'll go ahead and wrap things up for us. There are a couple questions that we weren't able to get to, but like Dr. Long mentioned, just reach out to them at the AltaVita Senior Resource Center. They're always available to answer your questions. If you have any questions that you wanted to submit to me from your Zoom invite, I can pass those along as well. And then also this webinar was recorded, so we will post this on our website, dailycamera.com/aging. And so you can access her slides and then this presentation as well through that website as well. So thank you so much, Dr. Long. We appreciate your time, and we'll be back same time tomorrow for our next webinar.
Okay, thank you.
Thank you.